This Week in Virology, the podcast about viruses, the kind that make you sick.
From Microbe TV, this is TWiV, This Week in Virology, episode 1140, recorded on Thursday, August 15th, 2024. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
The tie is really dark, but I'm going to guess it's a Diplococcus.
So close. They are these little cocci. They're in clusters, and they are a golden color. So think of the golden grape. So can you say grape in Greek?
Oh, yes, of course. I know what that is. Is that Streptococcus?
Staphylococcus aureus. Yeah, Staphylococcus aureus.
I mean, there used to be something was called Diplococcus because there were pairs, right?
Yeah, so that's strep pneumo, Diplococci. Yeah.
But you don't use Diplococcus anymore, right?
Some of us are old enough to remember that terminology and banter it about, but yes.
Because when I went to graduate school, that's what we called it. Diplococci.
Yeah, that works. That works.
Okay.
All right, well, let's jump in. We'll start with our quotation because we have a bunch to talk about tonight. And this is from Thomas Carlyle. He who has health has hope, and he who has hope has everything. And just really, sort of putting up there the importance of health and why we prioritize it. I think there's a famous Princess Bride quotation which sort of has a take on this, but a little more comedic. But all right, but let's jump into it. We got a couple here right up front before we get to COVID, and the first one is I think a really nice conceptual peer-reviewed article, Onward Virus Transmission After Measles Secondary Vaccination Failure, published in Emergent Infectious Diseases. So. Here we read the results of a systematic review aimed to assess transmission risk for measles after what they call secondary vaccination failure, or SVF. So these are going to be some new terms we're going to talk about today. So we're going to talk about primary vaccination failure, so PVF. And what is that? It's not breakthrough. This is a failure to seroconvert after vaccination, while this secondary vaccination failure, SVF, is something that occurs years after that initial vaccination, felt to be due to waning immunity.
Can I interrupt, Daniel?
Please do.
So why is it a failure? It's natural waning of immunity. Why is that a vaccine failure?
It is interesting. Like, why do we use terms like breakthrough, failure, all these other things, right?
Implies something is wrong, and I think it's biology.
Yeah, so we do need better terminology here. So let's talk a little bit more about this concept. So the first time, and this is actually an interesting. So this primary vaccination failure. Okay, so you vaccinate someone, you don't get seroconversion. If antibodies are critical, okay, so maybe I'll call that a failure of doing that. Now, the other idea, though, is years go by. We're going to talk about how many years, and then there's this waning, and then something happens there. So primary vaccination failure results from a person's failure to produce any humoral response to viral antigen, so non-seroconversion. And this is thought to occur in about 5% of measles vaccinees. All right, so 95% of the time you get a good antibody response, 5% of the time you don't. Now, this secondary vaccination failure, which we need to rename, seems to occur 6 to 26 years after that vaccine dose. And it is really, as you know, Vincent, as you bring up, it's a result of waning or some kind of incomplete immunity. And this occurs in 2 to 10% of measles vaccinated persons. Right. So we can sort of do our numbers, like 95% of the time you get a good antibody response, off the bat. And then somewhere between 90 to 98% of the time, those antibodies keep going. And should a person be exposed, we don't have disease, right?
So I bet after infection, you get the same numbers.
It would be great to know, right? I mean, this is stuff people could check.
2 to 10, I bet there's a fraction of people, because everyone's genetically different.
Yep.
A certain fraction are just not going to have long-lasting antibodies. So it's not a vaccine failure. It's just the way it works, the immune system.
This is the way the immune system works. And the interesting thing we're going to get at here, and it is good that we're actually talking about, because words do matter, right? So when we talk about failure and breakthrough, like it sort of feeds this anti-vaccine, and we don't want to do that. We want to talk about what's going on, and what you're going to see here is actually going to be a pro-vaccine message, which is this question. So someone gets vaccinated, 6 years, 10 years, 15, however many years go by, we get that contraction, that waning that we see over time. Now somebody goes and gets, they get infected, they get disease. And the question comes, is this really a failure? What about onward transmission? And I think this is also going to be helpful in sort of like, why are we trying to get a population vaccinated? How does whether or not you're vaccinated matter to me, to your neighbors, to your family, to those you love? So it's this whole concept of onward transmission, whether you're a naive, unvaccinated individual or you're an individual that has this pre-existing immunity from vaccine. So here the investigators searched PubMed, Embase, and Web of Science databases. Inclusion criteria are articles describing persons who are exposed to measles-infected persons who experience this this SVF, so sort of this late phenomenon. Across the included 14 studies, greater than 3,030 persons were exposed to measles virus from these SVF cases, right? Someone got immunized many, many years ago later. Now they actually have a measles case. What about the people that are around them? 180 were susceptible, and we end up with this secondary attack rate of somewhere between 0 and about 6.25%. They identified 109 cases of SVF from these studies. This is really the meat of it, right? So what is the reproductive number, the effective reproductive number for measles? Most of us peg that at greater than 10 for unvaccinated people. So you've got a person naive, they've got measles, they're around other people, they're going to spread it in general to greater than 10 unvaccinated people. Now, one of these people who've been vaccinated before actually gets measles. What is the reproductive for them? Less than 1, calculated to be 0.063.
So, Daniel, I think they're overlooking cellular immunity, and that's probably playing a role. They're just measuring neutralizing antibodies. Well, they're not measuring anything. It's a meta-analysis, but they're looking for neutralizing antibodies. And I'll bet these people have durable T-cell immunity, which is really doing the job.
Yeah. I mean, it is interesting too, like, because, you have this idea like, oh, but, these people, they got vaccinated and they still got measles. They may have still got measles, but it's not the same thing. Every case of measles is not the same. With a reproductive number of less than 0.1, you're really going to end the transmission. I mean, these people are not really spreading. And I think this is the kind of stuff that I would love to see. It's going to be hard at this point in time to get these numbers for things like COVID, right? But yeah, what is the onward transmission? We talked about the Pareto principle. We sort of had like 20% of the people spreading like, 80%. What was sort of the number that one person would spread to others? How many others would end up getting it? And it would be great to have, information now, people who've gotten a whole bunch of vaccines. Like, what is that doing for a population?
I think the bottom line here is that you shouldn't worry about it, right? Because even if a fraction of the population, their antibodies decline, they still are not going to really pass on the virus.
Yeah. I mean, I think this is really another very pro-vaccine message at a community level, saying
so Daniel, if a patient came to you and you did an antibody titer and, they'd been immunized many years before and it was 0, what would you do? Would you re-immunize or say you're not going to transmit?
Yeah, it's interesting. In the general population, we don't recommend routine revaccination.
Okay.
Now, there's a couple of situations, maybe in healthcare workers, right? And then there were the recent issues where we talk about, if you're going to be in an area where it's high risk, if you're going to be traveling to somewhere where there's a lot of measles, it's sort of interesting. I do this, right? I travel to these areas where there's a lot of measles going on, and to get like healthcare employment, they check these titers, and there are certain institutional-based recommendations. But we're really seeing here that you're sort of missing the boat if you just check antibody levels. All right. Now, the next one, this is something I've been getting a lot of questions about, and very timely, as in today, very timely as we're recording this. So August 14th, 2024, right? So that's Wednesday. We're recording on Thursday, the 15th. So August 14th, WHO Director General declares mpox outbreak a public health emergency of international concern, right? So we've renamed the disease mpox. We read in a news release from the WHO Director General Dr. Tedros Adhanom Ghebreyesus has determined that the upsurge of mpox in the DRC and a growing number of countries in Africa constitutes a public health emergency of international concern under the international health regulations. The emergence last year and rapid spread of a new virus strain in DRC, clade 1b, which appears to be spreading mainly through sexual networks, and its detection in countries neighboring the DRC is especially concerning, and one of the main reasons for the declaration of this public health emergency of international concern. In the past month, over 100 laboratory-confirmed cases of clade 1b have been reported in 4 countries neighboring the DRC that have not reported mpox before, so Burundi, Kenya, Rwanda, and Uganda. And experts believe the true number of cases to be higher, as a large proportion of clinically compatible cases have not been tested, right? So seeing lots of cases, and already confirming over 100 of these.
So Daniel, not very long ago, mpox, monkeypox virus spread out of Africa. So how is this different?
So the biggest thing here is we're talking here about a clade 1b. So there's clade 1, there's clade 2, and then there's variants within the clade. So this is a clade 1b. Clade 1 is felt to be more aggressive, a higher mortality. And so, yeah, this is not the same clade 2 where we did see some deaths in higher resource settings. This is a more aggressive virus, and it looks like we're seeing pretty significant spread. So, so we don't live in Africa, and while this Dr. Griffin keeps saying no one is safe until everyone is safe, this is Africa, Vincent. Should we be worried about this? Is this going to get out of Africa? Is it going to come to Europe?
Daniel, this has been ongoing for several years.
Yeah.
I don't know why we didn't deal with it before.
Worried about it, right?
Well, I mean, this is the problem, because people don't care until it spreads out of Africa.
Yeah.
And that's not right. They should have been vaccinating the population years ago. We have vaccines.
Yes.
And so that's the role of the WHO, don't you think?
Yeah, this is huge, right? I mean, so yeah, is that the approach? Like, did we only care about Ebola in West Africa because, it might leave West Africa, and while it's in West Africa, it's not our problem? It is the World Health Organization. It's not the, Western, or the entitled, resource-rich countries' health organization. It's supposed to be the World's Health Organization. And there were a lot of criticisms, even in West Africa, that a lot of the focus was keeping it from leaving West Africa, not even so much going there to really help the people that were suffering. And we've been talking about mpox for a while. All these people are getting it. People are dying. People are suffering from really a horribly painful, disfiguring disease. And we seem to only be getting interested because now it's this public health concern of international concern. And I think the suggestion was to really get this under control. They need about $15 million to move forward with the vaccination efforts, which in my mind seems like a very small amount of money.
It's too small, Daniel, right?
Yeah, it seems like a very accessible amount of money. Well, I should point out that, our hands have been in our pockets too long, because now, if you don't actually just care about people because they live in Africa and you're worried about yourself, well, the WHO just confirmed the first case of mpox outside of Africa. And so the WHO today, Thursday, recording this on the 15th of August, Sweden. So case in Sweden. Swedish health officials said at a press conference that the person was infected while they were in Africa. People do travel. And yes, it's clade 1b, the same that's involved in this recent outbreak. The patient is there receiving treatment in Sweden.
Daniel, it's my understanding you still need close contact to transmit, right?
Yeah, so that's something we talked a lot about when we were seeing cases here in the U.S. So in general, this is a very close contact spread. There was kind of that scary healthcare worker story, right, where a couple of healthcare workers went out to a patient's home and they put their gloves and everything on, but they did that after they had kind of already gone in and only put the gloves on like when they were ready to get samples, and so a couple of them actually got lesions on the hands. But no, in general, this is very close contact. As we're seeing, this is generally spreading through sexual networks. But there can be, we've seen this in children where it's not a sexual, it's just a physical contact exposure. But yeah, this is not in general, this is not a respiratory transmission. This is a contact transmission. All right, and moving into a respiratory transmitted pathogen, COVID, we have our map update, and I put in my glasses to read the small print here because in bright yellow, Puerto Rico, and the 4 to 5.9% of all deaths in Puerto Rico are still COVID, and a bunch of states, 2 to 3.9% of the deaths in Texas, Minnesota, Alabama, Florida, New Jersey are due to COVID. So not only are we seeing the wastewater continue to rise across the country, in the West, it's past where it peaked last January. We're seeing continue rise in the South. Again, the South is already up where it was last December, January, and yeah, all across the country we're seeing continuing exponential rise. All right, and just keep reminding people about PEMGARDA, the COVID passive vaccination. That's that prophylactic monoclonal antibody. We've started doing that at Columbia, and actually we're trying to get access here. Just yesterday, I was speaking to one of our hematology oncology docs about just all his patients who are at risk. They're pretty far out at this point from vaccination, and there's also the concern that they're not going to be great responders. And remember, that's that prophylactic monoclonal treatment with about a 70% risk reduction of developing symptomatic COVID-19. Early viral phase. So we have a fun article here, and it's really like a thought piece, right? So this is the article, Single Monoclonal Antibodies Should Not Be Used for COVID-19 Therapy, a Call for Antiviral Stewardship, written by some of our friends, Arturo Casadevall, Danielle Focasi, Lise Ann Pierovsky, and Shmuel Shoham, and this is published in CID. So here's the background. And I have to say, I'm sort of like, as I'm reading this, thinking about where would I have sort of weighed in on this, back in March of 2020. Where have I weighed in on this over the pandemic, and where do I weigh in now? But we read that it is an axiom of infectious disease practice that the use of a single agent for microbial agents with the capacity to rapidly generate escape mutants can lead to emergence of resistant microbes. So such a lesson was painfully learned over decades of clinical experience when single drug therapies led to the emergence and circulation of resistant strains. And I remember HIV, and in the early days, I was kind of the guy sitting there saying, because I had come from a tuberculosis background, saying, why would you possibly use one medication against this virus? And then I remember we would always, when they ended up in the hospital, we would stop all their meds, and then just the virus would run amok. So here we go forward. For example, and this is, I'm going to read from the article. For example, during a phase 2 randomized clinical trial of bamlanivimab, remember bamlanivimab?
Bam, yeah.
Yeah, I was actually the PI on the largest clinical trial of bamlanivimab, so very intimately acquainted with bamlanivimab. The prevalence of treatment emergent MAB-resistant SARS-CoV-2 was 7% in the treatment group versus 0% in the control group. So we saw this right out of the gates. When antimicrobial drug resistance emerges due to selection for less susceptible strains, these strains, I just want to kind of say variants here, by the way, these variants can be transmitted to others in the community and healthcare settings. This is also possible for resistance that is induced by the monoclonal antibodies. However, it is unlikely that the demise of the first generation MABs is solely attributable to selection of MAB-resistant variants, since SARS-CoV-2 spike protein mutations amino acid changes had already been documented prior to the rollout of anti-spike monoclonals in 2021. The most likely explanation for the short clinical life of the originally deployed mAbs was that they targeted single spike protein epitopes that were also targets of infection and vaccine-induced antibodies. So the authors here argue that while mAbs used for PrEP is justified, right, our PEMGARDA approach, our Evusheld approach, they're suggesting in this opinion piece that single mAbs should not be used for COVID-19 therapy.
I think that's reasonable, but Daniel, we can't even get physicians to use Paxlovid. So to think they're going to use a monoclonal anyway is probably dreaming.
Yeah, I mean, this is interesting because where do you go with this opinion piece, right? So for certain situations, let's take Ebola, for instance, right? If you've got Ebola and someone's acutely got Ebola, we might treat them with a monoclonal antibody. We might treat them with a small molecule. In the early days of the pandemic, right? So 2020, we really jumped in very quickly with convalescent plasma, also jumped in with the different monoclonal antibodies. So we had bamlanivimab. It was first by itself and then coupled with a second one. We had the Regeneron cocktail, which had a couple. A lot of the whole idea here, it was really going to be like a stopgap. And the whole idea that you always need to use a cocktail, it costs twice as much. There's increased production capacity, and did we really lose them because we used them one at a time, or did we lose them because you just had all these people getting infected? And this was actually the same target that people were producing antibodies to, and you were getting selection pressure against just from actual wild type viral infection. So I think it's an interesting piece. But I'm just sort of not sure where we go forward. And yeah, again, like we're not going to probably use monoclonal antibodies in the future for acute COVID-19 therapy. We're really trying to go and get people to use the small molecules. But yeah, as you point out, we're not even succeeding there. There's this whole mainstream media like, there's certain countries where they just don't even test. They don't even want to know, even though there's an effective therapy that can reduce progression by 80, 90%. And we're seeing ongoing issues, right? As we point out, when 4% of all the people dying in your state are dying due to COVID, there's a problem there because what is the biggest denominator at this point? Everyone's got immunity. Everyone's been infected before. Everyone's had a vaccine. The people that are dying are the people that are not being offered therapy. And that is a great segue into what is that number one recommended therapy by the NIH and IDSA? But
Paxlovid.
Yes, people, Paxlovid. Eventually, we might have some other choices, but right now, that's recommended. And don't wait. Actually, a colleague, texted me the other day, hey, I got a patient. They're thinking they want to wait to let that natural immunity kick in. Like, please don't wait. It's like waiting for something to happen with that patient having a stroke or a heart attack. What are the collaterals going to develop? No. The sooner you step in, the better effect you get. You really don't want that immune response. You don't want that cytokine storm during week 2. So Paxlovid, remdesivir, molnupiravir, convalescent plasma in certain circumstances. And unfortunately, the isolation guide is because you are sick, but you can make other people sick as well. And remember, just going to sort of reiterate this. For the first 5 days is when we see the most transmission. But let's say you're an elderly individual, your husband just got COVID, it's day 6 and you're like, I'm done with isolating. We're going to start sleeping in the same room. 10 to 15% of transmission is during that day 6 through 10, most of it day 6, 7. So just kind of keep that in mind when you're making your decisions.
So what is the CDC recommendation for which day are you okay? If you feel good that day 5, is that enough?
So day 5 is when they say, strict isolation. And day 6 through 10, they say, if you're going to be around others, you're supposed to wear a tightly fitting mask. So sleeping in a room next to your spouse without a tightly fitting mask, that's not, per CDC recommendations. So, you're rolling the dice and you're hoping that if you get COVID, your doc's going to get you going right on the Paxlovid. The really tough thing, and this is the public health issue that, we just have to be honest about, right? And this is great that we have this long format to say it, is in the early days when they talked about 14 days, when they talked about 10 days, you had about a 2% compliance.
Hmm.
So from a public health, that's useless.
Horrible.
It's horrible. So then it was like, I say negotiating with terrorists saying, okay, would you do 5 days? Would you at least do 5 days? And if people do 5 days and, even if you get 10% doing 5 days, that's actually going to be a more effective public health intervention than 2% of the people, 98% of people not doing anything.
So last night on the stream, someone said I had COVID. At day 5, I felt great. My test was negative. Can I assume I'm okay? I said, no, you shouldn't. You should probably wear a mask for a few more days.
Yeah, so I'm in the doctor's lounge, and that was this week. And one of the docs is joking about, oh, so I understand you took a trip to Alaska to one of the other docs, and I'm like, oh, really? Yeah, I used to work up in Alaska. He's like, no, I'm joking. I'm like, well, what do you weren't in Alaska? He's like, no, I had COVID, but it's okay. I'm all better. Today's day 6, and I'm like, where's your tight fitting mask?
Especially for a healthcare person, right?
Yeah. So they were wearing a tight fitting, N95. But that's critical because you say, oh, only 10% of the transmission, but the in-hospital mortality, like if one of our patients is in the hospital and then they get COVID while in the hospital, mortality is well over 20%. So, and that was, I was relating, I think, this story about that older woman, delightful woman, who was telling us how she was going to run for president in the fall. She came with a urinary tract infection, got COVID, and then she died of COVID. So, yeah.
So the problem is if you're in the hospital for some reason, and so if you get COVID there, it's high mortality.
Yeah, that unfortunately. Okay, so during that second inflammatory week, steroids, right time, right patient. This is the early inflammatory. It's not the rebound week. One of my patients was giving me a hard time on Tuesday. She's like, Dr. Griffin, she says long COVID. She's like, ever since I got COVID in July, I felt really like a setback, took the Paxlovid during that first week. I started to feel better, but then I got the rebound. And I was like, you're doing that just to torture me. She's like, okay, we'll call it the early inflammatory response. I was like, thank you. You can now be my patient. But yeah, during that early inflammatory week, steroids, right time, right patient, right dose. We have anticoagulation guidelines, pulmonary support, and remdesivir in some situations. We're still in the first 10 days, and still some limited use of the immune modulators. A lot of challenge there is right time with those. And all right, we'll focus a lot here on COVID, the late phase, PASC, long COVID, and really, I think I've got 3 articles here to talk about. First is just a mention, the article "Long COVID: Science, Research, and Policy," published in Nature Medicine. So some rock stars of long COVID in the author list here. And so the authors put forth this interdisciplinary review that provides a synthesis of the state of scientific evidence on long COVID, an assessment of the impacts of long COVID on human health, health systems, the economy, and global health metrics, and provides a forward-looking research and policy roadmap. A rather extensive discussion of the impacts of long COVID on individuals, health systems, economies, really a call to action to increase awareness, promote research, and I thought it was something, and training of healthcare providers to care for these patients, right? This is, I don't know if people know, but I'm a Swiftie, right? So I'm listening to the song Epiphany, where she talks about, we didn't learn about this in medical school. And so somehow if we're going to take care of these individuals who are suffering, and, her song Epiphany is about people with acute COVID. And I'm sort of thinking of this in people with long COVID. I mean, these are people's daughters, people's mothers, people's friends, and they're continuing to suffer. And a lot of clinicians out there are really stretched. This is a tough crowd to take care of. And we actually need training of healthcare providers so they really know how to care for these folks. And yes, over 300 references and open access. So I'll recommend that read. Now, a couple different things here, a couple more articles. Now, the first one, I think this is important. The article, Differentiation of Prior SARS-CoV-2 Infection and Post-Acute Sequelae by Standard Clinical Laboratory Measurements in the Recover Cohort, published in Annals of Internal Medicine. And this is just a word of caution about just doing those quote-unquote routine blood tests and finding nothing wrong. This study looked at 10,094 participants, 8,746 had prior SARS-CoV-2 infection, 1,348 were uninfected, 1,880 had a PASC index of 12 or higher, and 3,351 had a PASC index of 0. That sort of leads me to say, let's pause here. What is this PASC index? As part of the National Institute of Health's RECOVER, NIH RECOVER, Researching COVID to Enhance Recovery Initiative, I'll leave in a link, recovercovid.org. This group previously examined prospectively collected data from nearly 10,000 people in the RECOVER adult cohort with or without SARS-CoV-2 infection and identified 12 symptoms that best distinguish those with prior infection from those who are uninfected. And actually, if you dig through in the supplementary material, there is a table, supplemental table 1, symptoms included in the PASC index. And we've talked about this when this publication came out, but there's actually scores assigned per symptom. And, people sort of argue a little bit about like the scores and the points. So for instance, if you lost smell or taste, you get 8 points. But if you've got brain cognitive dysfunction, you only get 3. Right. So some people are like, really? Fatigue, right? We talk about people debilitating fatigue. I can't get out of bed. I can't go to work. You get 1 point. People a little annoyed. Yeah, the point. So, all that being said, what they really try to do here is say, let's take people like who really solidly have PASC 12 or higher. Let's take people with a PASC score of 0. So people who got COVID who do not have PASC. Let's look at SARS-CoV-2 uninfected. And then let's basically ask the question, if we do a whole bunch of blood work, what do we find? So we read that after propensity score adjustment, participants with prior infection had a lower mean platelet count, higher mean hemoglobin A1C, that's like a chronic sugar measurement, and urinary albumin-creatinine ratio. They do comment that differences were of modest clinical significance, and they point out that among participants with prior infection, no meaningful differences in laboratory values were found between those with a PASC index of 12 or higher and those with a PASC index of 0. So what routine, quote-unquote, routine labs did they do? So they did a complete blood count with differential, complete metabolic panel. They did an INR, they did a D-dimer, they did lipids, did a vitamin D, a thyroid stimulating hormone, free thyroxine. They did the hemoglobin A1C, a high sensitivity CRP, cystatin C, an N-terminal a BNP, troponin, urinalysis, urine albumin-creatinine ratio. And where did they come up with these? So these tests were selected on the basis of, one, routine availability, right? These are routine blood tests, ones that are standardized. Also, they look through the prior literature, and then sort of expert opinion, right? So clinical expertise of the investigators. And I'm going to say there's a lot to take away from this article. One is that people suffering from long COVID can often have normal routine blood work. So a word of caution there. While some patients seeking care might have a compelling clinical presentation, in some cases, biochemical and physiological abnormalities are consistent with long COVID. There remain no diagnostic biomarkers, and no one can rule out long COVID by just doing routine blood work.
How did they come up with these numbers? It is a matter of frequency of these individual signs and symptoms?
A lot of people were critical. There's sort of this idea that they felt like certain characteristics were more discriminatory, right? When people come in and they, I got some sort of a viral illness and I can't smell or taste, if it's congestion related, it tends to go away pretty quickly. But with COVID, it can linger. So they felt like, okay, that's pretty much, if you got that was from the COVID. That I got COVID and now I have this post-exertional malaise. I think it was really a goal to find discriminatory valued characteristics rather than necessarily the impact on quality of life. Like the fatigue, I can't get out of bed, I can't do that, giving it a point of 1, people were upset by that, but there's a lot of things that can lead to a fatigue. So sort of a discriminatory aspect.
So basically there's no common lab test that will distinguish people with PASC.
Yeah. So you can't do a blood test and say, oh, you've got it, you don't have it. So nothing that rules it in, rules it out.
We knew before, Daniel, right?
Yeah, but just good to point out. Just don't, docs are still doing this. Hey, I did a whole bunch of routine lab work. You look all fine. You must be malingering. Let's not be dismissive.
I mean, but there are other things that are different, right? That
Yes.
are not routine assays.
Yeah, and so that's some of the stuff we've talked about. We've talked about serotonin levels, serum
Mhm.
serotonin levels seen in different cohorts. We've talked about this low AM cortisol without a
Right.
compensatory ACTH. We've talked about this really off the chart EBV, CMV, and VZV serology tests, sort of consistent with this escape from latency during acute infection. And yeah, actually, when my review gets published, we'll go through what would be a reasonable panel of tests to do rather than this quote unquote routine panel. All right, and I think we just have two more to talk about before we get to emails. And one is risk factors for long COVID syndrome in postmenopausal women with previously reported diagnosis of COVID-19, published in Annals of Epidemiology. And so this comes from the Women's Health Initiative, or WHI, which is a landmark study dedicated to understanding chronic disease prevention strategies in postmenopausal women. A lot of studies previously looking at just sort of, old Caucasian guys. But during 1993 to 1998, 68,132 women enrolled in 3 overlapping randomized controlled clinical trials, and 93,676 women enrolled in a prospective observational study. All the women were postmenopausal and in the age range 50 to 79 years, and enrollment at 40 U.S. clinical centers. And here we're actually looking at data from this initiative. So using the WHI demographic, so that's WHI, not WHO, demographic and health data collected at study enrollment through the present day, machine learning identified the top 20 risk factors for long COVID. And then they looked at these variables with logistic regression models. So with an N of 37,280 survey respondents, 1,237 with a mean age of 83 reported a positive COVID-19 test, and 30% reported long COVID. So pretty high. Symptoms included an array of neurological, cardiopulmonary, musculoskeletal, general fatigue, malaise symptoms. And what did they find? Risk factors for long COVID: a weight loss of 10 pounds or more in the previous 2 years, sleep problems, limited physical and mobility, previous heart valve procedures, and rheumatoid arthritis. Physical function risk factors for long COVID were a limited ability to bend, kneel, stoop, or, you ready for this, grocery shop, as well as the use of a wheelchair, walker, crutches on level surfaces. So sort of our more debilitated folks going into this were at higher risk coming out the other side.
But certainly some very athletic people can get long COVID also, right?
Yeah, and I think that's always the thing. We're just talking about relative risk. Like
Yeah.
I've talked about, some of the triathletes that I have taken care of who, they've gone from being a triathlete to, I can't walk up a flight of stairs.
Hmm.
Right? So it hits all. It's just sort of a relative risk issue. And to finish with the article, long COVID symptom monitoring insights from a 2-year telemedicine study published in PLOS One. And so these investigators conducted interviews to evaluate long COVID symptoms at the 2-year mark and investigated whether patients had contracted a second COVID-19 infection between the 1-year and 2-year follow-ups and recorded their vaccination status. Out of 165 patients, 84% reported symptoms at the 1-year follow-up, while only 61% reported symptoms at the 2-year follow-up. So seeing some people getting better. Among patients with long COVID at the 2-year follow-up, the majority, they say, had experienced long COVID at the 1-year follow-up, received the SARS-CoV-2 vaccine, and had not experienced the second infection between the 2 follow-ups. Both having long COVID at the 1-year follow-up and contracting a second infection were significant risk factors for presenting with long COVID at the 2-year follow-up. So sort of that issue with getting another infection putting you at risk. And my comment here, there's a couple things here. One is, every time you get COVID can be sort of a setback, sort of sharing that experience of that patient that was torturing me by using the terminology of rebound. But also a comment here about the value of telemedicine. I mean, that was one of maybe the silver linings that came out of this pandemic, is we really got an uptick in the use of telemedicine and the introduction of telemedicine technology. But it really has been a great way for a lot of people to access care. It's really been great for people with long COVID. And for people with long COVID, it's daunting, the idea that they're going to somehow get to a physician's office, that they're going to wait around, they're going to then get seen. Somehow they got to get home. And then for a lot of them with post-exertional malaise, now the next 2 days are just a disaster. So for a lot of them, it's been great. Also, I guess it's great from my perspective to be able to see someone in their home, to be able to see like, well, what does your world look like, as opposed to just seeing them in sort of that sterile exam room. But it's also been great for hospital discharge, right? Someone gets out of the hospital and you say, all right, I want to see you in the next couple of days, make sure everything's going well. They're like, I just got out of the hospital. I'm supposed to come to an office. So great to be able to see them, making that transition to home. Are they on all the right medicines? And hey, is there anything going on that we need to do to keep you from bouncing right back? So really a lot of value here with telemedicine. So sort of nice to finish with a highlight there.
So the last TWiV, Daniel, 1139, was long COVID with Dr. Judith Bruckfeld. So she talks about the experience in Sweden with long COVID.
Yeah, I listened to that. That was a great episode. Yeah, it's really nice to hear the experience in another situation, another context. All right, so let us say no one is safe until everyone is safe. Hopefully a reminder in some of the stuff we covered today. But I'm hoping everyone would pause right here, go to parasiteswithoutborders.com and click on that donate button. I hope you appreciate what we're doing, but to keep doing this, we're going to need your continued support. And right now we're doing our Floating Doctors fundraiser, where for August, September, and October, we'll double your donations up to potential maximum donation of $20,000.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. DR writes, I recently had a brief sore throat. Thought it might be the beginnings of SARS-CoV-2 infection amidst this summer peak. However, 2 successive rapid antigen tests from 2 supplies were negative, as was a LAMP PCR. Although I've been diligent at testing and have enough lab experience to do it right, I've never tested positive during this pandemic. What is your current clinical experience with such high wastewater levels reported globally? Could there be lower viral loads in the respiratory system enough to evade detection while that in the GI tract is getting picked up? And does that say we should be developing urine and fecal tests for consumers? Furthermore, I saw mention on social media of the success of lenacapavir and HIV, which gives me the impression that we are sitting on our hands when it comes to developing antivirals for SARS-CoV-2 and thinking we're golden having relative success with mRNA vaccines. Your thoughts would be appreciated.
Yeah, so these are both great topics to bring up. So the first is sort of this issue, right? Let's say someone gets exposed. Let's say they have one of these abortive situations, which we've talked about in that exposure study that the Brits did, right? Where they exposed a whole bunch of young people. And some of them you actually were able to pick up like cellular changes, T-cell activation, things like that. But you never ever got a positive test, right? So sometimes are we seeing situations where that's happening? And then becomes the question of, does that affect what we would do clinically, right? Would those people really even benefit from getting an antiviral? We don't know the answers to those questions. So, I think before we start being so aggressive in developing urine and fecal tests, you want to sort of ask this question: does it matter? If your body is already able to keep that viral load down so low that maybe you're not even going to pick it up, would treatment even add anything to that? So that's my first sort of comment. The next is, yes, lenacapavir. We mused a little bit about this. With influenza, if there's an outbreak in a nursing home, for instance, we'll actually put everyone on the once-day prophylactic dosing of Tamiflu, and there's some evidence showing that does something. So, we really haven't found success with our small molecules in doing a sort of a pre-exposure or pre-positivity. But it would be interesting to keep working down that road because, particularly in a nursing home, that would be a great setting to have some sort of prophylactic or pre-exposure or even early post-exposure medication to use.
I think the GI RNA is a direct reflection of what's going on in the respiratory tract. You're swallowing mucus and it's passing through. There's no replication in the GI tract. So I don't think if you don't detect it in the respiratory tract, it's clinically irrelevant, I would say.
It's probably true. And I think, it'd be great to do the studies to say.
Okay, Rad writes, I'm a medical assistant at a Canadian cardiology clinic. Our clinic has been using surgical masks for all staff and patients since the beginning of the pandemic until now. We were wondering where the balance of the evidence lies in August 2024 on using surgical masks in such settings, and whether the drawbacks of masking, such as impaired facial communication, environmental waste, and discomfort, would be outweighed by the small but perhaps non-zero effect of masks for source control and disease incidence or severity reduction. We've been tuning into your episodes every week. And remember you mentioning the UMD study by Lai et al., TWiV 1120, which showed lower exhaled viral mRNA in N95, KN95 cloth masks in surgical masks, where the cloth masks slightly outperform surgical, although we don't know if 70 to 98% less exhaled viral load will be clinically significant in reducing illness severity. We also heard of the recent Norway RCT, which showed a 29% relative risk reduction in self-reported respiratory illness over 2 weeks, although it seems like that study has had some limitations, which lowers our confidence in its results. The control group reported going out more and vice versa for the surgical masking group. In other words, some have argued that this RCT tested the effect of masking as opposed to masks themselves. We know you may be unable to make broad recommendations about masking in healthcare facilities. What does the balance of evidence say? Do the personal and social cons of surgical masks outweigh the purported benefits in 2024?
Yeah, so this is great, Rad. You basically you're laying out the issues, you're laying out some of the evidence, and this is really the discussion that different facilities have to have. So certain facilities, I'll say here in the U.S., we use kind of thresholds, right? So a few weeks back at one of our healthcare systems, things got to a certain point. And it's sort of interesting in the communication because they talked about levels in our patients and our team members, right? So maybe people listening will know which healthcare system uses team members in their verbiage, and actually making a recommendation for going back to masking. And a lot of this has to do with what kind of patients are you taking care of, how much of a contact time, what is the risk situation, what's the ventilation of your facilities and the interactions. A lot of the outpatient settings that I work in are either just using surgical masks or some situations not using masking at all. But yeah, there is, as a lot of people have pointed out, there is impaired facial communication. Sometimes there can be an issue, particularly in older individuals who really are doing a lot of lip reading. There's this huge environmental waste impact. It still sort of kills me that even though we know that COVID is a respiratory transmitted pathogen, we're still putting on these yellow gowns and generating like 200 gallons a week per patient of this waste. It's not contact, it's respiratory. Time to get on the front page. I'm not sure about the discomfort. But yeah, so I think you're bringing up all the really important issues, and people at facilities need to have these dialogues and make these decisions. What's really the right choice for your facility, your patient population, and your caregivers?
Grazia writes, for the past 4 years, I have kept abreast of the latest research, including listening to your update. I feel you have armed me with pretty good info. I'm shocked that my doctors do not hold the same views as you when it comes to antivirals. My husband is 55 and recently infected for the first time. He attended a Seattle Mariners game, didn't wear a mask. He has Ehlers-Danlos. He called his doctor to get Paxlovid, as we have a high-risk child. The nurse tried to dissuade him from taking Paxlovid because it wrecks your GI tract and has questionable effectiveness. While I know about the GI side effects, I also know from your show that taking Paxlovid early in that first week is important to reduce symptoms and keep you out of the hospital during week 2. It may even help with forward transmission. Every doctor or nurse I have spoken with has minimized COVID and the use of Paxlovid. Why the discrepancy? Other than promoting TWiV, which I do, how can I change this perception among clinicians? When I asked my doctor about COVID a few years ago, she said, "You'll probably be fine." That didn't quell my fears. All right, why don't you take that one first, Daniel?
Yeah, let's start with this, right? I mean, it's really frustrating, and unfortunately, that comment about you didn't learn about this in medical school. Unfortunately, a lot of physicians, and I'm saying this, is they stopped learning when they finished their training, and a lot of them, the New York Times, the Wall Street Journal, Fox News, whatever their media of choice. That's what they sort of hear. And there's a little bit of an echo chamber they get into. Is this how we approach urinary tract infections? You'll probably be fine. 90% of urinary tract infections, they get better on their own. So I don't treat those either. When someone calls up a provider, they really want evidence-based guidance. And the fact that Paxlovid is based upon a really great randomized controlled trial, hundreds of other studies demonstrating the benefit. It's what is recommended in the NIH and the ID Society of America guidelines, and very solidly in the ID Society of American guidelines. I just sort of ask them, like, why are you not following the ID Society of America guidance on how to treat this infectious disease? That would be the society of the experts. Why this discrepancy? Where did you get your ideas? So sorry, but, and then the other is maybe you don't even need to have that dialogue. Maybe it's time for you to find an evidence-based provider, because we're out there.
All right. Our second question is about masking, not in a healthcare situation, but at home and at schools and so forth. What is what are you doing? Are your kids wearing masks at school, for example?
Yeah, so this is a challenge, right? And it's sort of, first off, is deciding which venues you're going to attend. Because some, crowded, poorly ventilated venues, I will often choose not to attend. You sort of ask yourself, do I want to be sick? Do I want to have all the consequences? It could be COVID. It could be any of the other different things. So the first is making a decision about the venues that you're going to attend. If for some reason you really like to go to restaurants, can you go during a time when it's not as crowded? Is there outdoor seating? Things like that. I'm going to be heading to Singapore and Taiwan soon. I was just making sure I have my N95s proper that I'm going to be wearing. The others, you got to decide how comfortable are you with the social aspect of wearing a mask, because there really is a whole emotion around this, And so, I think a lot of people have to ask, like, what are my personal risks? What am I willing to do? Because, as we're seeing, there is a societal impact to doing this.
And finally, what's your opinion about the CDC's push to seasonalize the virus and the vaccine? It's not seasonal. It's not like flu. Why is the vaccine offered only once a year? Shouldn't it be every 4 to 6 months?
Yeah, I mean, at least for, older folks, high-risk folks, we're really kind of getting to this realization that, like we talked a little bit with the measles as well, like there may be a population benefit to the more people getting vaccinated. Even if someone gets sick, maybe they're less likely to transmit it to others. So maybe there can be a population thing. So you point out correctly, COVID is not the flu. It's not just the winter. We have a summer surge right now. Our summer surge is as bad as last winter surge. Maybe it makes sense to get, these vaccines twice a year. But then maybe, as we'll find out, maybe, we put all our eggs in the mRNA basket. Maybe there's some other more durable approach that we can do.
All right, 2 quick ones. What Lori wants to know is if you can use Neosporin in the nose to prevent COVID.
So I think we studied that, right? Where there was this whole idea that you get this interferon response to shoving Neosporin, but they were not just shoving Neosporin or bacitracin up their nose. So we do not condone, we do not encourage this. And if you look closely at the data, it's not really clear that this is such a great thing to do.
And there's no clinical trial either, right, Daniel?
Yeah, remember this was the Akiko one where they were like, yeah.
And finally, Michelle says, my 35-year-old son-in-law took Paxlovid on day 1, felt better, felt sick a few days later, week 2, congested chills, lost smell and taste, tested positive quickly. Is he still contagious on day 12?
I'm going to say no. Let's just go through this, right? So as we keep saying, right, the most contagion is contagiousness, most spread is during the first 5 days. We see some 10 to 15%, day 6 through 10. We really have not seen spread in a 35-year-old healthy individual after day 10, right? So I remember there was this whole CDC recommendation, and I remember it was David Ho had this preprint, which I think later got published, where it really was a bunch of family members and sort of suggesting that there had been transmission in people having symptoms during that second week, but it was not after day 10 if you look at that. It was sort of confirming that you do see some transmission during that second week, but not seeing transmission after day 10. So if your son-in-law was day 12 and wanted to have lunch with me, I would not be worried that I was going to get COVID.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Thank you. And everyone, be safe.